All right, let's talk about something that can make any medical student's heart pound, the pediatric neuro exam. Today, we're going to zero in on the lower limbs and give you a solid, confident approach you can use even when the pressure is on.
So picture this. The examiner says, examine the lower limb. The clock starts ticking, and bam, the pressure's on. But here's the secret. Your exam doesn't start when you get to the bed. Nope. It starts the second you walk into that room.
Seriously, those first 20 seconds, they're pure gold. Before you've even asked the child to take a single step, you are already collecting vital clues. This is where you lay the groundwork for your entire assessment.
So what does that actually look like? Well, you walk in, you greet the examiner, you wash your hands, the usual stuff. But your eyes, your focus is already locked onto the child. That's your first touch point, your first chance to really observe what's going on.
And a really easy way to remember this is the 4 Ds. First up, dysmorphism. As you're saying hello, you're just glancing at their face for any unusual features. Next, distress. Does the child look comfortable or are they in pain? Then, devices. Quick scan of the room. Any splints, walkers, maybe a shunt? And last, dimensions. Just get a quick mental snapshot of their general size.
And get this, even a simple handshake can be a diagnostic tool. When you reach out to shake their hand, you're not just being polite. You're feeling for things like muscle wasting or myopathy. You've basically started your hands-on exam and they don't even know it.
Okay, so we've got our first impressions. Now, let's move on to one of the most revealing parts of the whole exam, analyzing how the child walks. We're talking about their gait.
And your very first question here is a major fork in the road. Can you walk for me? Simple, right? But the answer changes everything. If it's a yes, we dive into gait analysis. If it's a no, you just skip that whole section and go straight to the bed exam. This is a huge time saver when you're under pressure.
So if the child can walk, you're going to be watching them very closely. And think of this as your personal cheat sheet. Each type of walk or gait hints at a different problem, and each one has a special test to help you figure it out. Like if you see a really stiff, spastic walk, you're thinking upper motor neuron lesion, and you'll ask them to try walking on their tiptoes. Or say you see a waddling gait, you might suspect a proximal myopathy, so you'd test for something called Gower's sign. It's all about connecting what you see to what you do next.
All right, after you've watched them walk, but before they hop on the bed, it's time for a really good visual inspection. This is your chance to do a systematic sweep from head to toe while they're still standing up.
You really want to have a mental checklist for this part. First, make sure you have good exposure. Ask them to roll up their pants. Then, you're looking for muscle wasting, or the opposite, any unusual bulkiness, like that classic calf pseudohypertrophy. Scan for scars. Then, actually kneel down to get a good look at their feet. Are the arches super high? Then check the skin for any spots. And finally, take a look at their back for any curves like scoliosis.
And here is a fantastic clinical pearl for you. If you do spot what looks like scoliosis, just ask the child to bend forward like they're trying to touch their toes. If that curve magically disappears, it's probably just positional, not a true structural problem. It's a super simple move that tells you so much.
Okay, now for the main event, the hands-on examination. The child is on the bed, and this is where we're going to put all the pieces together with a really systematic approach.
And where do you start? Right at the foot of the bed. Seriously, before you even touch the child, just stand there and look. You're checking for any asymmetry, any difference in the length of their legs. It's such a simple observation, but it's so easy to miss if you're in a rush.
Now this sequence, this is your roadmap. Follow it every single time and you will not miss a thing. You start with tone, then you move logically to power. From there you check reflexes, and depending on how those reflexes are, you decide whether to test for Babinski and clonus. And you always finish up with coordination and sensation.
Okay, this next point is absolutely critical, both for being a good doctor and for getting the diagnosis right. You have to inspect the entire limb, and that includes the hip. But you must ask for permission first from the child, the parent, and the examiner before you adjust their clothing. Why is this so important? Because a tiny surgical scar from an old hip issue could be hiding there, and finding it could completely change everything.
Okay, so you've gathered all this data from your initial observation, from watching them walk, from your hands-on exam. Now comes the fun part, connecting the dots and building a real clinical picture.
So, let's play this out. Let's say during your exam you found this exact pattern of signs. Their muscle tone is increased, their reflexes are way too brisk, they have some weakness, a positive Babinski sign, and clonus. Now that is not just a random collection of findings. That's a classic pattern.
And that pattern points straight to one thing, an upper motor neuron lesion.
See, understanding these patterns is what takes your exam from just a checklist to being a powerful diagnostic tool. You're not just seeing signs anymore, you're interpreting what they mean. And here's another pro tip for you. Let's say your findings are pointing the other way, towards a lower motor neuron lesion. There is one thing you must never ever forget to do. Look at the tongue. I'm serious. Why? Because those tiny little twitches, or fasciculations on the tongue, can be a key sign of something like spinal muscular atrophy. And that is a diagnosis you do not want to miss.
Here's another great example of how one finding leads you to the next. Remember that ataxic or drunk-like walk we talked about? Well, if you see that, your next move should be to listen to their speech. You're listening for a very specific staccato, choppy pattern. Finding that just reinforces your suspicion that the problem is probably coming from the cerebellum.
All right, you've done all the hard work. You've found the clues, you've connected the dots. Now for the grand finale, and it's a big one, presenting your findings clearly and confidently before that bell rings.
And when you give your summary, you want to show the examiner that you're thinking bigger than just the legs. Using phrases like, "I would also like to perform a full neurological exam of the upper limbs," shows that you're thinking about the whole system. Or, if you're suspecting something in the spine, saying, "I would like to examine the genitalia," shows a really mature and thorough thought process. It tells them you know what you're doing.
So in the end, a neuro exam is so much more than just a list of tests. It's really about being a clinical detective. You're gathering clues, looking for a pattern, and piecing together the patient's story. Because the final question isn't just, "So, what did you find?" It's, what story are all these signs telling you? And learning how to tell that story, well, that's the real art of the exam.